Uh, Good morning, everyone. So we'll be starting an instruction course that's on PHAKIC IOLs. It's titled as All About PHAKIC IOLs, and in this session we are gonna run you all through of topics like how to start your PHAKIC IOL practice and what are the investigations that are needed for the same. And for the first talk, we are gonna invite Dr. Karishma Wadia. Dr. Karishma Wadia is very senior practicing in Bombay and has enormous experience in PHAKIC IOLs. So we'll tell Dr. Karishma Wadia to please come up on the stage, please.
Thank you, Dr. Mukesh, for this opportunity, and thank you, AIOS. I'll be talking to you about starting PHAKIC IOLs in private practice. So what are the investigations and what is the type of patient selection that you want to do in PHAKIC IOL surgery? So to begin with, we already know that there are different types of PHAKIC IOLs. The older version was anterior, as well as now there is posterior. Anterior chamber IOLs are not much in use, the reason being that they lie anterior to the iris. So because of which, apart from the huge cosmetic blemish, they also can have a lot of chances of corneal endothelial touch, which can lead to decompensation. The main advantages of posterior chamber PHAKIC IOLs are they lie behind the iris, so they are far from the endothelium, they have excellent cosmesis, they are close to the nodal points of the eye, so they actually give a far superior quality of vision to the patient than any other procedure. There is also a gain in the retinal image size, again because it is closer to the nodal point, and there is a greater effective optical zone. Because they are sulcus located, the most important advantage is that they are stable, easily removable or exchangeable, no fixation to any tissue, and it does not alter the shape as any refractive procedure will do. So currently you have a couple of options. You have the Star Surgical, which is the Vision ICL, you have the Care Group, which is the IPCL, you have ICRL, and you also have RIL from Appaswamy. The indications, the first and most important indication which you should know of is the age, of course. Now on paper the age is 18 years, but preferably, because this is a surgical intervention where you enter the eye, you would want to voluntarily tell them that we would like to wait till the age of 21. You have to have a documented stable refraction for at least 1 year, and you need to inform that to the patient. There is a lot of them who will come and say, no, let us do it anyways, I've had number, etc. Patients who are not suitable for corneal refractive surgery anyways, they come to you for PHAKIC IOL because they have not been eligible for LASIK or the number is too high. The most important prerequisite would be AC depth more than 2.8 millimeters in myopia and 3 in hyperopia. Endothelial cell count needs to be good and no other ocular pathology. So your contraindications would be any ocular pathology starting from the cornea, corneal dystrophy or endothelial cell count less than 2000. AC depth, if it is not adequate, you can't put in a PHAKIC IOL. If there is any history of uveitis, any presence of anterior chamber or anterior or posterior synechia, then you want to abstain from doing such a lens. Glaucoma, even if you are slightly suspecting it, you would want to avoid. Evidence of nuclear sclerosis, of course, you want to avoid because you'd rather remove the lens itself. And any personal or family history of retinal detachment. This is important because there are studies that show that the risk of RDs increase after you have entered with a PHAKIC IOL in very high myope patients. So what do we check? Everything. Don't leave anything. Starting with visual acuity and refraction, you need to do a dilated refraction as well. AC depth from endothelium, your iris configuration, your axial length. So you would want to do an optical A scan, which also gives you the lens thickness like lens star. Dilated evaluation, check for the crystalline lens. Does it have any phacodonesis? Are the zonules okay? Is there any zonular weakness? Check the angles. Do a proper gonioscopy to evaluate the angles. You can also do an ASOCT to check what is the anterior chamber status. Glaucoma has to be vigilantly checked for. You need to check your IOP by applanation. You need to check white to white, which I'll be talking about. You need to do your pupillometry and a detailed retina checkup. Now in this retina checkup, don't do a regular retina checkup on the slit lamp. Get a proper retina specialist to do an IO with indentation so that you have gotten retina clearance. Ultimately in this procedure we are entering the eye, so you want to make sure everything is a 10 on 10 before you operate. So coming to refraction, do a cycloplegic refraction. Make sure that you have documented stability. These cases are more difficult in keratoconus and post-LASIK ectasias than post-RK. Get a specular done. Let the patient know that yes, we are doing these additional investigations not just randomly, but because this has to be safe for the rest of your life. So a lot of them get demotivated because there's extra tests that you need to do, but you need to emphasize on the importance of that. So endothelial cell count should be done, and minimum cell count of 2000 is okay. Now anterior chamber depth, you can check this in various ways. Clinically is not okay. You will need to do a objective assessment. So you can get that on your ultrasound A scan, you can get that on an optical A scan, tomography or OCT. So usually if you have done an IOL master or any optical A scan, there will be a display which shows you what the AC depth is. For example, in this case it is 4.03. In a topography, if you have, then again the topography will show you what the anterior chamber depth is. And what is more important is that you should know in that machine whether it is showing you the AC depth from endothelium or epithelium, because you need to know the AC depth from endothelium. Coming to white-to-white measurements, again, you can do it with the digital calipers. You also can get your measurements on optical A scans. You can also get it from tomography like Pentacam and OBScan. And Autoref also sometimes gives you white-to-white measurement. What is most important is this particular measurement, the most important determinant for your appropriate phakic IOL sizing. Manual is the best method, but there is a high inter-observer variability. You need to order a digital calipers, which we'll be showing you in the video that follows, and parallax has to be considered. What you need to do is, you need to take the reading from the mid-limbus to the opposite side mid-limbus, not the outer, not the inner, middle of the limbus. And what you need to do is, you need to take 3 readings so that you can send them for the sizing. So you should not be using regular manual calipers, because you will need a digital one. You also get very good white-to-white measurements on the OBScan, but the availability of the OBScan currently is a little tricky. For the white-to-white measurement, this is a small video to show how it should be taken. Under topical anesthesia, you take your digital calipers. As you can see, we go from mid-limbus of one side to diagonally opposite mid-limbus. It's very important that you explain this additional procedure also to the patient, because ultimately you are adding one procedure apart from the investigations. You are going to take him into OT, do this, and then order. So again, more intervention. This will show you your digital reading. You will take 3 such readings, because whatever phakic IOL you are using, they will ask you for multiple readings of optical A scan, of topography, as well of white to white. So each of the phakic IOL sizing is based on the combination of these factors, the white to white as well as the AC depth. You can also do a UBM pre-op analysis. We used to do this regularly when we were back when we were fellows, because it gives you a good sulcus to sulcus measurement. You also get to check the anterior lens rise, which is the crystalline lens rise, which is the distance between the anterior pole of the crystalline lens and the line that connects the 3 and 9 o'clock angle recess. Now, in the volt, which is something that you are going to check post your surgery, okay, this you need to check mandatorily for everyone to know whether your phakic IOL patient is stable or not. You need to check the distance between the center of the posterior aspect of your ICL and the anterior pole of your lens, okay. The ideal volt would be anywhere between 300 to 900. So to summarize, you need to have proper selection of the patient. You need to do a good counseling of the patient to tell them all the things that we just spoke about. One is the number of investigations, one is the additional procedure for white to white, and ultimately the fact that you are now entering the eye to do a phakic IOL and comes with its own risks, which we will be further talking about. You need to take accurate measurements, so don't compromise on doing manual measurements versus optical scans. Proper counseling is very important, and it is also important to have trained staff to help you with all this. But the ideal thing that you should remember is, for these patients, because they are not going to come as in volumes as much as your other patients, make sure that you step in and take these measurements yourself if possible. Thank you very much.
So once we have decided that what all has to be done for starting a phakic IOL practice, the next thing is selecting which phakic IOL you're going to go for. Given times, we have so many phakic IOLs in the market, and to speak upon this, we have Dr. Ridhima Bagli, who's going to speak about selecting the different phakic IOLs.
Good morning, everyone. Thank you very much, Mukesh, for this introduction. So I'm going to discuss the various phakic IOLs that are available in the market, and I'm going to talk about the features of each one of them. So I think I'll start off with, I have no financial interests with any of these companies that I'm going to discuss with you. There are three types of phakic IOLs, just like Dr. Karishma had mentioned in her previous talk. The first kind are the angle-supported or the anterior chamber phakic IOLs. The second, the iris-fixated phakic IOLs. And in India, the popular ones are the sulcus-supported phakic IOLs. The angle-supported ones are now withdrawn from the market, and the main reason behind that is the endothelial cell loss that these lenses led to. Also, a toric version was not available with these, and I have personally used the Acrysoft Cachet. I've also explanted a few that had resulted in cataract. This is just an image. However, they are no longer in use in any part of the world. However, the iris fixated ones are quite popular in a lot of European countries. In the UK, they are the phakic intraocular implant of choice when they are going for a phakic IOL. This is an FDA approved Verisi phakic IOL, commonly called the artisan lens in Europe. It is a rigid PMMA lens it's an iris claw lens, and it's available to correct myopia from -3 to up to -23 diopters. Also, a toric version is available and a hyperopic version. A foldable version of the same, the VeriFlex, is also a popular implant. It has a polysiloxane optic with PMMA haptics, and this is the foldable version of the same artisan lens. However, the lenses that are more popular in our country are the sulcus-supported phakic IOLs, and we have quite a few, but the most popular is the Evo Vision ICL from Star. This is a single-piece plate haptic lens. It's foldable, and it's made up of a biocompatible material called Collamer, which stands for, it's a collagen and hema copolymer. It's a very thin lens, and it's placed in the sulcus. It sits behind the iris. So the advantages are that it's closer to the nodal point of the eye. It has better cosmesis. It's far away from the cornea, so the endothelial cell loss is much lesser as compared to the other lenses. This would be my lens of preference wherever I have to choose a phakic IOL implant, because they've been the pioneers and the market leaders of phakic intraocular lenses. Their material of the lens is patented, and it's a very soft, pliable lens. So in this video, I'm just showing you, for any reason, if you need to explant the phakic intraocular lens, and you may need to do it if there's a sizing issue, a refractive surprise, if it leads to a cataract later on, in cases of, like, I have explanted, I think, at least 3 of them, and with an ICL, it's such a soft, pliable lens that you can see in this video just a gentle, consistent pull, and the lens would fold upon itself and easily slide out of the eye. So this is with regards to the material and ease of explanting it. Yeah, it's not like, I've not edited the video, so and it would fold upon itself and come out through the same, like, 3mm wound, versus another phakic intraocular lens. The materials are different, and they are not going to fold upon themselves if you need to explant them. So here you can see the wound is being slightly enlarged, and the lens would come out without cutting it. You can still get it out, but not through the same 2.8mm wound, okay? So, and I'm also happy with the customer support. If you have errors with a refractive surprise, you need an IOL exchange for some reason, you would get really good support from the company. So the ICL was the V4 model, is the first one. When I started using it, it came in sodium chloride solution, and it was available in 5 sizes from 11 to 13mm. And with the sodium chloride version, we usually used to wait because it would hydrate in the eye and the size of the lens would increase. So we would wait to measure the vault and then judge the sizing and place an order for the other eye lens after that. However, from the V4 to the V4B version and V4C, they are now available in BSS. That's the balanced salt solution, and they come in a hydrated form. So the size, the power of the lens remains unchanged in the eye compared to what you get it as. The current one, the Vision ICL V4C, is the popular version now that comes with a central hole called the aqua port and Centraflow technology. That means that the aqueous has a more natural flow through the lens, and that helps in nutrition of your natural lens. You can do away with iridotomies if you have the courage to avoid them entirely. Also, it helps in reducing the incidence of an anterior subcapsular cataract. It helps in better visco removal at the time of surgery. So the design of the aqua port, it's a 360 micron, a tiny hole at the center of the optic of the lens. And as I said before, there are also two tiny perioptic holes as well to facilitate removal of visco. The size of the port, how did they come up with 360 microns? If the size of the hole is too large, that could interfere with the visual optical quality of the patient post-operatively and also result in more glares and halos. Versus a very small port would then have a risk of getting occluded and a rise in intraocular pressure. Also, a potential for streaming. It's a very small port. There would be a jet of aqueous hitting the corneal endothelium and could cause an endothelial cell loss. So the current size of port, the results have shown that the optical quality, if you compare it, the modulation transfer function versus a regular V4B ICL is unchanged. And the results for quality are more or less comparable. So the Vision ICL is available to correct myopia from -0.5 diopter is the power of the lens up to -18, and a toric version is available up to 6 diopters of astigmatism, while the hyperopic lenses are available from up to 10 diopters with a 6 diopter cylindrical power. This is the optic size or the optic zone diameter for the ICLs, starting from 5.8 millimeter optic size for up to a -9 diopter, and the size of the optic goes on reducing as the power of the lens increases. However, the current, as you may have heard, EVO stands for evolution in visual freedom, and EVO lenses, the concept has been enlarging the size of the optic zone of the ICL. So the optic diameter now is almost 20% higher than the V4C model, and that is to do with the pupil size in mesopic conditions. Studies have shown that in youngsters between 20 to 40 years of age, the pupil size is at least 5.2 to 5.4 millimeters for night driving or reading in low light. And so if the pupils are large in low light conditions, the potential for optical phenomena like glare, higher order aberrations, halos is more. And hence the optical diameter of the ICL has been increased to I'll show you the table, but up to 14 diopters of power, the optic size zone has been increased, and these have been labeled as the EVO Plus lenses, whereas from 14.5 to 18, they're the original diameter, and they are now called the EVO lenses. So, in vitro studies have not shown a dramatic change in the higher order aberrations that have been measured between the EVO and the EVO Plus lenses. However, they are thought to definitely benefit people with larger pupillary diameters. So if the original V4C model had a 5.8 optic diameter, now it comes as a 6.1 diameter. So this is just a video to show the loading of an ICL. It comes in a BSS glass bottle, and it comes with a special cotton tip applicator, which is used to pick up the ICL. Placed in the cartridge, there's a special forceps that holds the lens, and it's hence loaded. The surgical steps as seen here, like after side ports and an HPMC viscoelastic, a 3.2 mm wound is done. The lens is always loaded as an inverse TACO. And this is a slow implantation to show you, demonstrate the implantation and tucking in of the haptics. I think Dr. Mukesh in his subsequent talk is going to elaborate more on these surgical steps and tips and tricks so that to make it a little easier for you. But this is just to show you, demonstrate the loading of the ICL versus the other lenses that I'm going to discuss further. There are a lot of situations wherein as I said, it's available only up to -18 diopters. So what if the refractive error of your patient is -22, as is seen over here, I think 22 and 24. Or also I had this case with mixed astigmatism, and I actually have a refractive center where I do quite a bit of corneal lasers and SMILE, but mixed astigmatism is definitely one of the categories where I will tell the patient that you will have a residual error, you may have regression, you may need retreatments. With retreatments, there's risk of epithelial ingrowth. So I have done this many times with femtoLASIK, and for this particular case, the PAKI was also about 480, and I thought, let's go ahead with a phakic IOL. That would be a better option than corneal laser. I did the calculation for the STAR ICL. It showed that it would leave about a 1.25 residual SIL in both eyes with a 6 diopter cylinder. However, when I contacted the company, these lenses were not available. They said they would take at least 3 months to manufacture them, and there would be with the lenses they had available, there was almost a 2+ cylinder remaining. So then my next best option was the IPCL from the Care Group, because they do make custom ordered lenses for different powers, different sizes, and they had a 7.5 cylindrical power available with them. I got the lens in about 6 weeks time. So the IPCL is what I'm going to discuss next. It's been available since 2014, and the version 2 with the central hole was launched in 2017. It's available in 40 countries, not just in India, and it's quite commonly used in other parts of the world as well. It comes with a central hole, and it has these optic margin holes. So these have to be always oriented superiorly when you implant the lens. They also have these haptic margin holes to ease in the tucking in of the lens. They have, instead of just 4 haptics, they have 6 points of contact for better stability in the sulcus. They also have these notches to help with the orientation of the lens. It's available in more extended range of sizes from 11 to 14 millimeters, and the regular lenses come up to 22 diopters of myopia, with 6 diopters of hyperopia, but there is a custom diopter range which is quite great, because you'll commonly get patients who have more than 20 diopters, and up to 15 diopters of hyperopia is also available. So the central hole of this lens is slightly different in design. It's conical in shape versus the regular hole of the ICL, and it's thought, the company says that is to reduce the incidence of light scattering in photopic as well as mesopic conditions. The light scattered and lost is both lesser with this kind of design of the hole. Also, these haptics have a spring effect with the intention that even if you're a little 0.25 millimeters off in the measurement of the white to white on either side, it would not result in that much of a difference in the vault. So they're less white to white. Design is dependent less on the white to white measurements compared to the ICL. Also, there's a universal alignment. That means it's always has to be oriented at 0 to 180 degrees. There's no need to rotate an IPCL at all. So this is usually the alignment of the IPCL. And this notch here has to be on the right side. As you're looking at it, in the right eye as well as the left eye, this is the notch right here. And these are the optic edge holes that always have to be oriented superiorly. There is also a press biopic version in 5 sizes that the IPCL comes in. This is another patient where I preferred to use the IPCL. The white to white was about 10.7 millimeters, and with the ACD is about 2.88. So at least the ACD should be about ideally 3 millimeters. worst, like the borderline reading would be about 2.8 millimeters. So it's a small ACD, small white to white. So it's a small anterior chamber. And I did not want to go ahead with a 12.1 size. The ICL is available in these 4 sizes. A 12.1 millimeter ICL I thought would be quite big. So the IPCL gave me the option of an 11.5 or an 11.7 millimeter lens. And still the post-op vault is about 600 micron. So you need to be vigilant and choose what lens you want to go ahead with, not just based on what the patient is willing to pay you, but also based on, keep a look at what you would end up with. So this is just a quick video to show you the loading of the IPCL. So this is the toric version. Marking is done just 0-180 for all cases. And the initial steps are similar. Instead of a 3.2 or 2.8 millimeter clear corneal temporal incision. And the loading is similar to an IOL. HPMC in the cartridge. I'm just tucking in the edges of the lens. And instead of a reverse taco here, I'm loading it as a taco, like a regular IOL. And that's the lens going in. This is the left eye. So you can see that the edge holes are superiorly. So when you load, they have to be oriented on the right side for the left eye. And then tucking it in and removal of the viscoelastic. Another biotech phakic IOL is also a good lens. It is a hydrophilic acrylic material with a central hole, available with up to -23 diopters, and comes in 3 sizes. It again has easy loading, good results. The injecting is a little tight, but it's a good injector system. The results are also very good. The toric version is also available, and I've used these also quite a bit. Again, I'm just showing you the same. Just the orientation marks you need to be aware of. They are different for each lens. Like for the biotech lens, the orientation marks would be for the left leading haptic and the right trailing haptic. Again, this is their side ports being made, intraocular, preservative-free lignocaine, viscoelastic, a 2.8 mm clear corneal incision. Loading of the lens is quite similar to our regular intraocular lenses, but just that you have to be, and you need to ensure that it is convex side up. And again, I'm loading it like a regular IOL, like a taco. Just ensure that the edges are in. Press down the lens and gently, gradually injecting it into the anterior chamber, ensuring that the mark is on the leading left haptic and it's opening, unfolding the right way. Visco over the lens and tucking in the haptics. So I'm not going into the surgical part of it. And the last lens that we have available with us is the Appasamy RIL. It's available in similar dioptric ranges and sizes. It doesn't have a central hole as of now. And so I do not use it that commonly. Again, there's a right trailing, there's the marks are reverse on this. If you compare it with the biotech, there's a mark on the right leading and the left trailing haptic. However, the injecting system and the implantation techniques, every anterior segment surgeon would be familiar with it. So you can see the orientation mark right there. So to summarize, I would say the results, you need to base your choice of lens on the outcomes and the results of your phakic intraocular lens, your comfort and convenience of using, loading, injecting, and ordering your lens. For the STAR ICL, you need to be trained and certified for them to allow you ordering of their lenses and use of their lenses. I would always prefer one with a central hole. I personally do not do an iridotomy anymore, but I know a lot of surgeons still prefer to do it. Another determining factor could be the affordability of the patient, but sometimes you also need to base your choice on the range of powers and sizes that are available and provided to you. So thank you very much for your kind attention. If you have any questions, I would be happy to take them. Next, and help us with tips and tricks to implant these ICLs.
few things. I think RIL has now come up with a central hole in their lenses. That is number one. Number two is when we are planning phakic IOLs, as Dr. Karishma and Dr. Ridhima has covered, that the chamber depth for myopic should be around 2.8 millimeters minimum. But as we go for the higher dioptric power, for example, if you're planning something which is more than 14 or 16 diopter lenses, these lenses are very thick in the mid periphery. So although if you have a good vault in the center, the mid periphery may be a little shallow. So if you have a higher dioptric power, it is rather that the chamber depth minimum should be 3 mm. And when it comes to hyperopia, the standard guidelines say that the ACD should be at least 3 millimeter, but it's preferred that the ACD should be at least 3.2 millimeter, because the vault and the cataract developments in those hyperopic lenses are very quick, and they don't have a central hole. Yes. Yeah, so my talk will be purely to the tips and tricks of phakic IOL, and I will be just showing some of the videos in this part of my presentation, and I have no financial interest in the order of the volumes that I do. I use a lot of care groups IOLs, and then the star, then the ICRL phakic, and then the APA RIL. And the things that I'm going to cover are these, and without a further ado, I'm going to start with the loading part, because actually you win the half battle if the loading is proper, because that's how finally the lens is gonna go inside. This is a little detailed video because I wanted everyone to have a look. We first take the cartridge and inject the balance salt solution, followed by a HPMC viscoelastic added to a little bit. This is the ICL taken from the vial, and directly here you can see the orientation, the right upper side and the left lower side. There is a hole which tells us that the orientation is absolutely perfect, and it is tucked well inside. Now it's a pull mechanism, so you use a special forceps, you go in and you try to pull. So it's both the movements. So you take the forceps, pull it this side, and you take the cartridge on the other side so that it comes to the nozzle. And you have to also see at this point that there's a central hole which can be seen exactly from over the top. And then following this, you just put it into an injector and you're ready to put it in the eye. So loading part has to be done before even draping the patient. When it is the surgical part, well, I'm going to show this video. Yeah, so we are going to make the regular side ports and the main ports. Nothing much. This only thing is the direction of your port has to be bang on parallel to the iris. You can't have inclination towards the crystalline lens or towards the endothelium. I use the intracameral phenocane in almost all cases. Now this is an HPMC. As it is normally recommended to use an HPMC, but recently I have shifted to sodium hyaluronate, which makes it easy to get it out of the chamber. This is the typical noodle stage. We do not overfill the chamber because that was going to push the iris diaphragm behind and makes it difficult for us to put the lens behind the iris. So we do not overfill the chamber. For a star ICL, please increase the incision to around 3.2, makes it very easy. What you can see in my left hand is a MUKESH manipulator that works as a guard. So in case the phakic IOL doesn't open the way I want to, I can always take care with my guard on the left side. So this is what is very important, having a guard on the left side. Now, once you have the phakic IOL absolutely sitting nicely over there, you have won almost the battle, and just have to tuck in the lens. The learning curve is fairly, it's not at all steep. It's very easy. Only thing is management in cases where you have the inverted or the flipped phakic IOLs is going to be a little difficult, but otherwise the insertion and tucking it underneath the iris is fairly simple. Now I'm going to fast forward a little bit here to show you that So the visco that if you sit on the lens and try to do an IA, a visco actually from behind can be seen replaced by the fluid, and it comes out very nicely. So I'm hydrating the main port because it's no more needed now. I'm just gonna use the IA port to do the irrigation aspiration, and I take a lot of time. I take full 1 minute or 1.5 minutes so that the visco from behind the phakic IOL is easily taken out. I'm not sure whether you're able to see, there will be the bubbles underneath the phakic IOL, which will be slowly are coming towards the central hole, you can see, and you'll be seeing that the fluid is replacing the visco underneath it. And you need a lot of patience for this. You make sure that entire visco is out. I have now recently shifted to sodium hyaluronate, which comes out as a bolus, so that kind of saves the time, and almost no IOP spike that has been seen. The next case I'm going to skip because it's the IPCL. If time remains, I'm going to come back. What I need to emphasize is this particular video of the importance of second instrument. I have the next two videos to show you, if in case you land up in a situation where there's going to be flip, how you're going to manage that. So you see that I have my guard already there, and I'm slowly injecting the phakic IOL there. And somehow I realize that it's not gonna open the way I want to, so I hold it there. Give the injector to my assistant. I always have two instruments, and I am not allowing it to open. I'm keeping it well away from the endothelium and making sure I use the second instrument to position it in the way I want to. So in this way I can prevent. So the second instrument is very important. We just can't have anything inside. Otherwise you wouldn't have control. It would have flipped open. Now at this I was a little worried about what happens to the endothelium. So in the next video I'm going to show you something about again my guard goes in from the left hand, and I'm injecting. You watch the bubble at 7 o'clock, so that's going to be very important there. Again, once my lens is inside, it's not opening the way I want to. It's going to flip open on the other side, so I hold it there. You observe the bubble which is at 7 o'clock. I'm making sure that the lens is not opening. It is staying there. It is staying away. Now the bubble is between the instrument and the endothelium. Observe this. It remains way till the end, and I just push it open from the other side, and the lens opens in a perfectly normal way. So this way the second instrument is very important in making sure that your phakic IOLs opens in a proper way. This is a phakic IOL of IPCL. I think I have time to show this, so I will show this video. This is again just the loading of the IPCL. I use only the BSS for loading here. I don't use much of a visco now. This was the old video where I used to use viscoelastic, but almost now I just do it under the BSS as per the company recommendation guidelines. I think Ridhima, you have already shown this. I'll skip this. This is IPCL only. I just shown the this thing part. So I think that's it from my side. Thank you so much. I invite the next speaker, Dr. Varun Kharbanda, for his talk on complications of phakic IOL. Dr. Varun from Allahabad, please come.
I thank all of you for making this effort of coming early on the Sunday morning. And now that we've heard wonderful talks about the pros of the IPCL or the ICL or the phakic IOLs, I'm going to just play the devil's advocate and show the other side of the coin as to what all can go wrong, and I will try my best to also be able to help you about how to go about managing it. I have no financial interest. So this, in a nutshell, are all the complications mostly that you can face. We can divide them into intraoperative and post-operative complications. We will tackle all of these points one by one in the coming sections. So the most important complication that can happen intraoperatively actually starts right from the time you load the lens. I think my previous speakers have made the point very clear that proper orientation, proper loading, making sure the haptics don't get caught up in the side of the injector. These are all very important, because how your IPCL or ICL or your phakic IOL will behave in the anterior chamber depends totally on the ease of insertion and the orientation of insertion. While loading the lens, we should be careful about not grasping it too tightly, not grasping it from the edges, because these are very sensitive edges. You might just end up ripping them, especially for the ICL. Moving on. So this is what happens when you have an inadequate incision. Sometimes the blades are not to the measurement. You think you've made a 2.8, but it's actually 2.75. And it's just going to make the entry of the lens that much more difficult. There'll be more resistance, and there are more chances of the lens changing the orientation, getting flipped or getting reversed. Like I say, it cannot be stressed enough that the ease of entry, the ease of loading will actually do 70% of the work for you. We can see that there is resistance and the lens is opening in an orientation that, would not make you comfortable. So just make sure that the entry is adequate. This is not a phaco where we can't have leaking wounds. If you have any doubt in your mind, you can go and extend the wound a little more just so that your injector goes in, there is less resistance. This is again flipped entry. I think Mukesh just spoke very beautifully about this. You need to keep your wits about when it is opening. It sometimes becomes difficult to understand which direction it is opening, and you have to take evasive action as soon as you figured out what's going wrong. This again has to do with the loading, the orientation of the injector cartridge while you insert the lens. What happens after the flipped entry, or what happens if you are not able to stop or correct yourself? The lens actually gets in the AC inverted. The biggest thing that you have to keep in mind is, if you have an inverted entry, never ever try to manipulate it in the AC, because that is invariably going to cause endothelial damage. More importantly, it might cause anterior capsular damage, and you might end up getting a cataract way sooner than you had expected. So this is part of the video that Dr. Ridhima was showing. You can see that instead of a reverse taco, it opens like a classical taco. Instead of using a second instrument, she uses a viscoelastic. But again, as shown in the video, taking it out is not at all difficult. You just enlarge the wound a little and very gently keep tugging at it. You have to be careful that you don't pull it all at once. You, in a way, milk it out, and it will very easily fold upon itself and come out, and you can reuse this lens. It's not like it's not usable. If you're gentle enough with it, you can always reuse the lens. And if it does get damaged, most of these companies have a provision to replace your lens at least once, so you don't really lose anything from your pocket. You can be patient, you can counsel the patient and move ahead. Other infrequent intraoperative complications are like any other that we have. We can have iododialysis, iris bleed, iris can prolapse if the wound is too big or too shallow. There can be intraoperative pupillary block, especially when the visco gets stuck in the central hole. And of course, like I mentioned, if there's too much of manipulation in the AC, you might end up with very early cataract due to trauma to the anterior capsule. Now, this is what we all need to be very careful about. We are all at a stage where ICLs and IPCLs are being used in the bigger cities and the bigger centers. I come from a smaller place. People are still skeptical about the really long-term complications of the IPCL, and that is where all of this planning and all of this follow-up comes into the picture. Primarily, we all know that the vault, the AC depth, the sizing is very important. So what is the ideal vault? There used to be a thought process that between 250 to 750 microns is supposed to be the ideal vault. But long-term follow-ups have shown that the vault actually reduces with time. So the current understanding is that you can aim to have a vault anywhere between 400 to 800 micron, because with age, not only does the vault reduce in size, the lens also swells up. So people who are going to get cataract, say at the age of 50 and 55, are starting to get it at 40, 45. So a little extra vault does not hurt. Here are two pictures showing the high and the low vaults. So we'll start with the high vault related complications. Angle closure glaucoma, it's very evident. The vault will be high, the iris would be pushed anteriorly, it will press on the angle, which is why all the central holes and the iridectomies. But again, sometimes the iridectomies might get blocked by the haptic of the lens, sometimes pigment blocks the holes. So this is something you have to keep in mind. And if you have a high vault to begin with, you already have a handicap, and if any of these situations arise in the future, you'll have your hands full. Pigment dispersion, again, this happens because of high vault. The lens keeps rubbing against the iris. The people who are susceptible to it, there's a lot of pigment dispersion. It can get deposited on the lens, causing difficulty in visual quality. It can go to the trabecular meshwork and cause pigmentary glaucoma as well. Corneal decompensation is one of the very dreaded complications, and again, it's all very self-evident. I'm just trying to point out what all you can expect. If there's a high vault, there's endothelial touch. Studies have shown that even in an uneventful phakic IOL surgery, you have anywhere between 8 to 10% of endothelial cell loss in the first 2 to 3 years. Although it does stabilize after that, but there is definitely endothelial cell loss, and a specular microscopy is an absolute must in your workup for a phakic IOL. Pupillary block, like I just mentioned, it can happen due to the PI being blocked by the haptic, or the hole being blocked by pigment. So just need to keep that in mind. We also have a small percentage of patients who are steroid responders and people who have retained viscoelastic, but those conditions generally resolve within the first week. This is the big one, cataracts. That's the end of the game for anyone who's going for phakic IOL. And mostly, like Mukesh said, they're anterior subcapsular, but surprisingly, they don't happen right in the center. They happen in the paracentral areas, because that's where the ICL and IPCL is the closest to the lens. So the typical cataract that you will get would be right in the paracentral area. This is a small video, something that Dr. Ridhima mentioned and Dr. Mukesh spoke about. This patient is an ICL patient and presented with cataract. So your cataract remains the same. There's only one additional step, that is removal of the IPCL before the surgery. So this patient was a 40-year-old female. Is it running? Video. Hang on. Let's see. Let's see. Yeah. So you can see the cataract. Now, this patient presented with a toricity of about 2.78 diopters, and we decided to put a toric IOL in it. That's the surgery. So basically, you do your toric markings, you make your usual wound. Explanting an ICL or an IPSL is actually much easier than it even looks, because this material is very, very pliable and almost never forms any adhesion. So you can be, you can rest assured and go in and take it out from the sulcus. It's not like your usual IOL explantation. Although you have to orient it properly, because you need to get hold of it from your haptic-optic junction. That's the strongest point of the IPCL. If you just hold the haptics from the periphery, or if you go at the optics, those are the thinner parts. So you might just end up tearing it or taking out a part of it. But if you orient it properly and go to the optic-haptic junctions, then it's actually very easy. This is the same point where you use while implanting to tuck in the lens behind the iris. Excuse me. And once it is out, you just proceed with your usual cataract surgery. I do have to confess that it's kind of disheartening whenever you have this, because it's a journey that you and the patient started with the hope of spectacle-free life with least amount of collateral damage, and then you end up taking a cataract out of a 40-year-old patient. It's quite painful, but it is what it is. Yeah, nothing special here. You just Another complication that used to be common with anterior chamber IOLs was pupil ovalization or pupillary capture. That would happen when the haptic would entangle the root of the iris. But sometimes it happens with posterior IOLs also, especially in patients who are hyperopes or where the vault is very high. This is a very interesting video of something like that. Usual treatment is just miotics, and you can even try this in the OPD. You can, try to make the pupil constrict and dilate in front of the slit lamp multiple times, and sometimes it gets free on its own. However, if miotics don't work and these tactics don't work, you can always take the patient to the OT, tap the lens in the center and try to disentangle the iris. It's not very complicated, rather simple. But these are things that you can, at least you can keep it at the back of your mind that these are the possibilities. Again, decentration and rotation, especially in toric lenses. So there are two things about decentration. Something I forgot to mention when I was talking about the high vault. I'm sure all of you know about it, but I'll just refresh your memory. When you orient the IPCL or phakic IOL horizontally in the eye, the vault is actually a little higher. So if you have a case where your post-operative vault is higher than you expected, the first thing you should do is try and rotate it vertically inside the eye, provided it's not a toric IOL. That will give you an additional safety of about 150 to 200 microns at the most. So that is the first thing you do. So what will happen is, if there is an IOL which you plant horizontally and in the eye it turns vertical, even if it's a non-toric vault IOL, so you will be targeting a vault of about 300-400 and you end up with a vault of about 200. And of course it's a sizing issue. You can try and go in and again put it in the horizontal axis, but if it is a permanent issue, it is not going to just become all right with rotation. You might have to explant it, but trying to rotate and put it back in the original place is definitely worth one try. And again, for toric lenses, again the same thing, because the sizing is so important. If you undersize it due to any reason, then half the battle is lost. Because this is an IPCL. IPCLs are implanted horizontally from the temporal axis. This was a lens. This was rotated, I think, a third time, and you can see it's about 15 to 20 degrees off axis. Re-rotation is a very simple procedure. You just make the two wounds. You can see intraoperatively itself the lens is shifting, which means that it is a sizing issue. If this one rotates once again, I'm going to explant it. I've decided, but you always hope against hope that maybe this time is the last time and this time it stays. And that's about it. Other post-operative complications, again, like any other surgery, retinal detachments, because most of these patients are very high myopes. There can be zonular dehiscence in patients who already have weakened zonules, because there is a constant touch between the haptics and the zonules. Glares and halos used to be there earlier with the anterior chamber lenses. They are there more in the Western population because the mesopic pupil is 4 to 5 millimeters in size. Our mesopic pupil is more between 3 and 4 or 2.5 to 4 millimeters. So it's not so common in the Indian population. However, if your patients do experience that, you can always use miotics. Uveitis, TAS, and endophthalmitis, like any other surgical procedure. And SIA, if your corneal biomechanics are unpredictable, or if your incision is too large or too long, you can end up with some unplanned astigmatism. I would like to thank Dr. Himanshu Matalia, Dr. Mukesh, Dr. Ridhima, and Dr. Karishma. And thank you very much. I'll be happy to take any questions.
Yeah, we still have time for questions. Just to add a little bit, the last slide which he showed about the retinal detachment, yes, it is very important that at the follow-up also that the retina evaluation is done. I do the retina evaluation initially for the first year every 6 months, following that annually. In our set of data, we had around 150 patients, and 2 of them landed up in a retinal detachment because they are primarily very high myope. Not only that, perhaps Perhaps I would also share one really sad sad event that happened with a patient. The patient developed a myopic CNVM later on, for which an intravitreal injection was given, following which he developed a retinal detachment. So the purpose is to tell that these patients have a really weak retina, and it is mandatory you do a frequent checkup, because these type of complications can only be prevented by just frequent retinal evaluation. Point number 2 is related to the haptic location. Although these are sulcus fixated lenses, many a times we have seen, because of the anterior insertion of these zonules, they really don't go and sit inside the sulcus properly. There are many studies which have shown that it doesn't go this way in a sulcus, but if they are entangled into the zonules, or with the zonules being too anterior, it folds up and then irritates the back of the iris, which causes the pigment dispersion. That is one thing that one needs to take care of. I would also just like to emphasize regarding biometry. If you have a phakic IOL which develops a cataract, nothing different has to be done. Only thing is you do the regular optical biometry. Most of the time you will be landing up pretty close to the emetropia only. And I would like to ask Dr. Ridhima, how do you counsel the patient? Suppose if the patient has developed a cataract, how are you going to counsel the patient, and do you have any particular lens selection post-operatively for the patient? Because they're very high myopes and they really want the spectacle independence. Usually you will see that the patient is demanding for spectacle independence. You still go for trifocals if the power is available, or how?
So you're saying the cataract is developed post ICL, like an anterior subcapsular cataract. So I've seen 2 to 3 patients, but okay, I've seen about three patients, out of which the first 2, the anterior subcapsular, very faint cataracts, were not visually significant. They're not the kinds that progress rapidly. They're not age-related nuclear cataracts or posterior subcapsular cataracts. So usually if they're very early, I would still observe and follow up and see if they're causing symptoms to the patient. If at all a surgery is required, I've had one patient that it progressed quite rapidly. She was expecting, and the cataract, I think this was the patient that had post-operative inflammation after the ICL. Like she had an unexplained, like a TAS reaction in one eye after the ICL implantation, and about 2 years down the line she came to me with a cataract, and it needed to be operated. The patient was very motivated for a trifocal lens because she was in the young age group. She was not willing to wear a full near edition. You also need to, however, see whether the IOL power calculation is not an issue, but matching an ICL in one eye and a trifocal lens in the other eye, I have not gone ahead and done that. I have done one, and I have gone ahead with a monofocal lens, honestly, because considering the age of the patient. I think, however, if the patient is very motivated, I would go ahead with the trifocal lens, yes.
Yeah.
Do you prefer doing bilateral simultaneous phakic IOL implantation?
Never. I never do bilateral simultaneous phakic IOLs. There is I don't find a need of doing bilateral, because anyways I need to monitor the vault first of the patient.
So you would see the vault and then place an order for the...
No, I order both of them, because most of the times I'll end up with a pretty good vault, but I do the other eye after 1 week. Yeah. And any questions from the audience? We still have time. Yes, sir.
I have a very basic question. How we will decide the patient will require ICL or IPCL?
So I think I had a talk on that, sir. Like, it's honestly comes down to your first is the surgeon's preference and choice and comfort. It's not like the brand is different, the material of the lens is different. However, I think Mukesh said his lens of preference is the IPCL, while I said my lens of preference is the ICL. However, I do use the IPCL in a lot of cases where the size or the range of power or the finances, they are an issue. But I think it's not one is better than the other. There are many studies that have shown good results, predictability, safety, stability. The entire power is going to be corrected with both. So it honestly comes down to each surgeon's preference in choosing which phakic IOL he's more comfortable with. With the ICL, you need to be trained in loading the lens. You need to be certified you need to have an account with the company for you to access the online calculation and ordering their lens. They do not want everybody to use their lenses and end up, so they make sure that a select few are using their lenses and giving quality outcomes. So you need to be certified to load and implant an ICL, whereas in IPCL the loading and the implantation comes easily to any cataract surgeon, and it's more accessible, and so it is popular because it's more accessible to more surgeons.
Thank you.
Yeah, if any other question, one, you can take one last question or we can sum it up. It's already 10. Yeah.
Okay, one last question. What would you say about doing a corneal laser procedure in one eye and a phakic IOL in the other, or would you prefer phakic IOL in both?
Yeah, I'll prefer phakic IOL in both. I have done these, and I had a patient who had a -5 in one eye and -16 in the other eye, and she's still very happy with the -16 phakic IOL that I have done. Yeah, because the quality of vision is very good with these phakic IOLs. It's extremely happy. These are the most forgiving lenses, even if you have a residual refractive error of even a little -1 with -1 cylinder. They are very happy because the -16, -18 has been taken care of. So they are very forgiving lenses. The quality of vision is amazing in them. Yeah.
Thank you very much. Thank you to the audience for your